Think about the last time you felt a tweak, maybe a persistent ache after a workout, or perhaps that sharp pain that just stops you in your tracks.
Hmm.
Chances are it was your muscles or tendons letting you know something wasn't, well, quite right.
Absolutely.
These incredible tissues are just so fundamental to every single movement we make, from simply standing up to high-level athletic performance. But it's easy to take them for granted, isn't it, until they start complaining.
Very easy. We often only notice them when there's a problem.
Welcome to the deep dive. We take a stack of sources, the latest research, clinical insights, expert perspectives you've shared with us, and we dive deep. We try to unearth that crucial knowledge, those genuine aha moments,
Hmm.
and sometimes the surprising facts hidden within. Our mission really is to cut through all that information overload and get you truly well-informed, quickly, engagingly on these complex topics.
It's a vital service, I think. There's
Yeah.
so much information out there.
Today, we're taking that deep dive into the fascinating and, let's be honest, often frustrating world of muscle and tendon injuries and how they heal, or sometimes perhaps don't quite heal perfectly.
That's a key point, the not quite perfectly part.
And to guide us through this really intricate landscape, we have someone who possesses a remarkable ability to synthesize diverse information, provide real clarity on these often misunderstood topics, drawing directly from the detailed source material we have in front of us.
Well, thank you. It's a real pleasure to be here. Muscle and tendon issues are, well, they're universal, aren't they? They affect everyone from the elite athlete right down to someone just trying to walk comfortably.
Absolutely.
And the sources we're looking at today really highlight just how complex these tissues are beneath the surface, and crucially, how much goes into keeping them functioning optimally, or trying to restore that function when things do go wrong.
Okay, let's unpack this then. Our sources cover a huge territory, really, from the microscopic building blocks all the way through to diagnosis, treatment, and even some really cutting-edge approaches. Where do we logically begin this exploration?
I think the most logical starting point, as the research suggests, is really with the fundamental structure and function of these tissues. Before we can understand injury or healing, we need to understand what's normal.
Makes sense. Get the foundations right first.
Exactly. So let's look at how muscles are built and then their crucial partners, the tendons.
Right, the foundational building blocks. Starting with muscle, it's not just one monolithic type, is it? The sources suggest there's specialization built right in.
Precisely. Skeletal muscle isn't uniform, not throughout the body, nor even within a single muscle sometimes.
Oh, interesting. Why is that?
Well, it's because the body needs to generate such a wide range of movements and forces. Everything from, maintaining subtle posture for hours, right up to producing explosive power for a sprint or lifting a maximum weight.
A huge range.
A huge range. And this finely tunable output, the power the muscle generates, it's fundamentally a product of two things: the force the individual muscle fibers can generate and the velocity, the speed at which they can contract.
Force and velocity.
And that velocity, the speed, is largely dictated by different versions or isoforms of a really key protein called myosin heavy chain, MHC.
Ah, yes, the MHC isoforms. I remember seeing those detailed in the sources, linking them directly to speed.
That's right. We typically classify muscle fibers based on which MHC isoform they contain. You have type I, often called slow fiber, which primarily contain MHC1B.
Slow, okay.
Then there are intermediate fibers, type I, containing MHC-IA. And finally, the fast fibers, type Is, containing MHC-IA.
So slow, intermediate, and fast.
Exactly. And the critical functional difference lies in their ATPase activity level. Myosin is an enzyme that breaks down ATP for energy for contraction.
Right.
The MHC1B in those slow fibers has significantly slower ATPase activity. The sources point out it can be 7 to 9 times slower.
7 to 9 times, wow.
Compared to the type EX fibers with MHC-Is, that's a huge difference in enzymatic speed.
So it's not just a simple slow and fast twitch then, but there's this whole spectrum, a gradient of speed dictated by this specific protein's activity.
Precisely. A spectrum.
And muscle power output depends on regulating both the force and the speed.
Exactly. Both the force and the velocity depend on the inherent properties of these different muscle fiber types, and also the characteristics of the motor units.
Which is the nerve and the fibers it controls.
Spot on. The motor neuron from the nervous system and all the muscle fibers it innervates, and crucially, how these motor units are recruited by the brain and spinal cord.
Ah, the recruitment pattern.
Yes. This precise control over which motor units are activated and how fast allows for that incredibly finely tuned output the sources mention. It enables everything from picking up an egg very gently to well, attempting to lift a car.
Okay, so muscles have different fiber types, recruited in specific ways to contribute both force and speed. That's clear. Now let's shift to their crucial partners, the tendons. They connect muscle to bone, transmit that force. How are they structured to handle such immense loads?
Tendons are truly remarkable structures, load-bearing marvels, really.
Yeah.
On the outside, they're encased by a sheath called the peritoneum, which helps reduce friction.
Okay.
But internally,
Mm,
it's a complex hierarchical structure. It always reminds me of a sort of braided cable.
like a rope.
Exactly. The
Mm.
most basic building blocks are collagen molecules. These assemble into tiny, incredibly strong collagen fibrils.
And the sources get quite specific about the size of these fibrils, don't they?
They do. Their diameter is specifically mentioned because it actually varies depending on the functional role of that particular tendon.
Yeah.
It ranges from about 20 nanometers up to 150 nanometers.
Quite a range. Depends on the job it has to do.
Precisely. And these individual fibrils then aggregate, they bundle together to form larger bundles. The sources refer to them as subfascicular, secondary, and tertiary bands.
Okay, layers of bundling.
Yes. And all of these bundles are surrounded and separated by another internal layer of connective tissue called the endotendon.
So it really is like ropes twisted together into bigger ropes, all separated by sheaths inside.
That's a very apt analogy, yes. And a key structural feature that gives the tendon its incredible tensile strength is that the vast majority of these collagen fibers and their bundles are aligned almost perfectly with the main axis of the tendon.
The alignment is critical.
Absolutely critical. This specific alignment ensures that when the muscle pulls, the force is transmitted efficiently along the tendon towards the bone. And this ability to resist load is closely associated with the average diameter of those collagen fibers we just mentioned. It's a structure purpose-built for tension.
It makes perfect sense. You want everything pulling in the same direction. Now, where the muscle and tendon meet the muscle-tendon junction, or MTJ, this must be a critical zone, how do these two very different tissues connect so seamlessly?
The MTJ is indeed critically important, but it's also often a vulnerable transition zone. It's where the force generated by the muscle is efficiently transferred to the much stiffer tendon.
Right, managing that transition in stiffness.
Exactly. And the connection isn't a simple flat surface. The tendon fibrils don't just butt up against the muscle fibers. Instead, the muscle fiber membrane forms these elaborate folds, almost like fingers interlocking with the tendon.
Cover, increasing the surface area.
Precisely. It dramatically increases the surface area for the connection, which in turn spreads the load over a much larger area, reducing stress concentrations.
That makes sense.
And then at an even finer level, the sources describe very, very fine filaments, only 2 to 7 nanometers in diameter. And these are oriented approximately perpendicular to the main force vector.
Perpendicular, like cross-bracing.
Almost like microligaments, yes. They connect the terminal myofibrils, that's the contractile machinery, within the muscle fibers directly to the collagen fibrils of the tendon. It's a marvel of precise micro-level linkage.
That's incredible detail. And is this junction static, fixed? Or does it change and adapt over time, perhaps with training?
Here's where it gets really interesting. What's fascinating is the significant plasticity at the MTJ.
Plasticity, meaning it can change.
Yes. The sources point out the ability of the muscle side of this junction to develop new sarcomeres, those basic contractile units of the muscle fiber, specifically at this transition zone.
Wow.
This happens with growth, development, or as a result of things like muscle hypertrophy, getting bigger or prolonged stretch.
So it can actually grow new contractile units right there at the connection.
Exactly. This allows for localized changes and regional specializations right at the interface. It shows just how dynamic and adaptable this critical connection zone is. It can remodel itself based on the demands placed upon it.
So it's not a fixed point at all, but a living, adaptable connection that can grow and change. That's crucial context for understanding how these tissues respond to load. Okay, moving on from structure, let's talk about how tendons actually behave, particularly under load. They aren't just simple elastic bands that stretch and recoil instantly, are they? The sources mention something called viscoelasticity.
They're definitely not simple elastic bands.
Yeah.
No. Tendons are classic examples of viscoelastic materials.
Viscoelastic. Okay, break that down for us.
It means they possess properties of both elastic solids, which deform instantly under load and return to their original shape when the load is removed, like, say, a rubber band.
Right.
And viscous liquids, which deform over time under a constant load, like honey slowly dripping.
Okay, solid and liquid properties combined.
Exactly. So the response to load isn't instantaneous and linear, it's time-dependent. And it's also dependent on the speed, the rate of the applied load.
So a bit like pushing on silly putty versus, I don't know, pulling on a strong spring. The response depends on how fast and hard you interact with it.
That's actually a good analogy to grasp the concept. Yes. When you stretch a viscoelastic material and hold it at a constant length, the force required to maintain that stretch decreases over time. That's called stress relaxation.
Stress relaxation, okay.
Conversely, if you apply constant force, the material will continue to deform or stretch over time. That's called creep.
Creep, got it.
This time-dependent behavior is really key to how tendons function in the body. It allows them to store and release energy, but it also makes their response quite complex.
The sources detail specific testing methods used in the lab to understand these viscoelastic properties, right? Can you walk us through that?
Yes, they describe a typical viscoelastic testing protocol. This is often used on, say, isolated tendon samples in a lab. It usually starts with preconditioning.
Preconditioning.
Yes, that involves cycling the tendon through a few stretches and releases first,
Yeah.
just to standardize its mechanical state and get a consistent response for the subsequent test.
Right, get it settled.
Exactly. Then comes stress relaxation testing. The tendon is rapidly stretched to a certain length and held there, and you measure the decrease in force over time.
Okay.
Frequency sweeps involve oscillating the tendon's length at different speeds or frequencies. This lets you see how its stiffness and its energy dissipation properties change with the rate of loading.
And ultimately, to understand their maximum capacity, I assume they test them until they break.
Exactly. A critical part of understanding the mechanical limits is performing a ramp to failure test. Here, the load or the deformation is steadily increased until the tendon actually ruptures. This determines the maximum force or stress the tendon can withstand.
Makes sense. What factors, besides the inherent tissue properties themselves, can influence this mechanical behavior, both in the lab testing and, importantly, in a living body?
Well, several external factors matter quite a bit. Temperature, for instance, has a notable effect.
Temperature. How so?
Decreased temperature tends to make tendons less viscous and more elastic, meaning they might become stiffer and perhaps less able to absorb energy quickly. This is why controlling temperature, often using a water bath set at body temperature, is important during lab testing to try and simulate in vivo conditions.
Right. Mimic the body's environment.
Precisely. And the rate of loading also has a significant impact. The sources explain that these rate-dependent mechanical changes in tendons are associated with how the wavy structure of collagen, called the crimp,
The crimp. Okay.
how that straightens out, that's called uncrimping, and also with volumetric contraction of the tissue under load. Loading it quickly activates different responses and uses different mechanisms of deformation compared to loading it slowly.
Fascinating. And getting accurate data during these tests sounds incredibly critical if you want to draw valid conclusions.
It's absolutely vital. The sources really emphasize the importance of accurately measuring the tendon's cross-sectional area. Ideally, this is done using non-contact methods like laser-based systems during the testing itself,
Why is that so important?
because that measurement is essential for properly reporting the material properties,
Yeah.
like stress, which is force per unit area.
Yeah.
It allows you to compare samples of different sizes fairly.
Ah, okay. Standardizes the results.
Exactly.
Yeah.
Also, accurately measuring strain, the percentage of deformation or stretch, requires non-contact techniques as well. Things like optical tracking of markers placed on the tendon surface. This helps reduce errors from, say, grip slip when you're mounting the tendon in the testing machine.
Grip slip, right.
You need to know exactly how much the tissue itself is deforming, not just how much the grips holding it have moved.
Right, measuring the tissue's intrinsic response, not the equipment's limitations. That covers the lab side quite well. How do live tendons in our bodies, respond to the loads they experience every day, or perhaps during exercise?
Well, in vivo, the response is complex and primarily cell-driven.
Cell-driven.
Yes. When you apply tensile load to a living tendon, it causes mechanical deformation of both the extracellular matrix, that's the collagen, and the ground substance and the cells within it, the tenocytes. These tenocytes are mechanosensitive. They sense this mechanical loading and translate it into biochemical signals.
So the cells feel the stretch and react.
Precisely. This cellular response leads to changes in ECM protein production specifically, changes in both collagen degradation and production. It's a constant turnover.
And there's a specific timing for this cellular response, isn't there?
Yes. The sources indicate there's a definite temporal pattern. Peak collagen synthesis, the building of new collagen, occurs around 24 hours after a bout of loading.
24 hours.
And this elevated synthesis can remain for up to 72 hours. This increased turnover of matrix proteins is thought to be a fundamental part of maintaining normal tissue homeostasis, keeping the tendon healthy, strong, and adapted to its usual loads.
Does it matter how the load is applied? Do different types of muscle contraction impact this tissue response differently? Say, concentric shortening contractions versus eccentric lengthening ones, or even static isometric holds?
That's a good question. The sources suggest that the different muscle contraction types don't seem to affect the synthesis or degradation of collagen in fundamentally different ways, provided the total tendon strain is similar.
Ah, so it's the amount of strain that matters most.
It seems so. Any differences seen in studies are likely related to the amount of strain or load experienced by the tendon during that type of activity, rather than the specific muscle contraction type itself. It's not just collagen either. Other matrix proteins like proteoglycans also show increased turnover in response to exercise, contributing to the overall adaptive capacity of the tissue.
So the tendon is constantly responding, remodeling, adapting based on the mechanical load it experiences. This dynamic process is usually brilliant, but sometimes it goes wrong, leading to injury. Muscle strains, for example, are incredibly common, aren't they?
They are, unfortunately, very common. Muscle strain injuries are among the most frequent and, frankly, debilitating injuries in sport and recreation.
Debilitating, definitely.
They can have significant short-term impacts, like substantial time lost from work or activity, but also worrying long-term consequences, sometimes making it difficult for individuals, especially athletes, to regain their pre-injury performance levels.
A real challenge.
It is, and the sources highlight that despite how common they are, the exact location of damage, particularly within that crucial muscle-tendon junction we discussed,
Right, the MTJ.
and the predisposing factors in what seem like healthy, uninjured muscles are still areas of active study and debate, though our understanding has certainly expanded significantly.
Okay, and what about tendon issues? We used to hear the term tendonitis all the time, implying simple inflammation. But the sources really seem to challenge that idea, suggesting a different primary problem, especially in chronic cases.
Yes, this is a crucial shift in understanding that the sources really reinforce. There's been a significant move away from viewing chronic tendon pain solely as tendonitis, implying primary inflammation.
So it's not itis, meaning inflammation.
Not primarily, no. The source material clearly states that tendinopathy, particularly in its chronic forms, is often characterized by degeneration rather than primary inflammation. A classic example cited is chronic lateral epicondylitis, tennis elbow. Histological studies often show a striking lack of significant inflammatory cells.
Really? No inflammation. So what does this degeneration actually look like at a microscopic level then?
In what's often described pathologically as tendinosis, you see distinct microstructural changes. There's often a loss of collagen continuity. The collagen fibers aren't neatly aligned and organized anymore. They might be disrupted or fragmented.
Disorganized.
Very much so. There's typically an increase in what's called ground substance, the sort of non-collagenous matrix material. The tenocytes, the tendon cells themselves, also show changes. They can be more numerous, more rounded, looking different from the normal flattened tenocytes.
Okay.
And you often see increased vascularity, the ingrowth of new, often disorganized blood vessels into areas that are normally relatively avascular, meaning they don't usually have much blood supply.
So it's not classic inflammation. It's more
No.
like tissue breakdown and a kind of disorganized, failed healing attempt.
That's a very good way to put it, yes. A failed healing response.
That fundamentally changes how we should think about the problem. If it's not just inflammation and it's often degenerative, what makes someone susceptible to developing tendinopathy? The sources list several risk factors, painting quite a multifactorial picture.
It's definitely not a single cause. It's a complex interplay of factors. Age is a significant risk factor mentioned, associated with both degenerative pathology and tendon rupture risk.
Age? Right.
However, the sources add an important nuance. Aging alone doesn't fully explain it, while structural changes like increased stiffness, decreased deformation capacity, increased cross-sectional area, and decreased peak stress and strain are observed in older tendons. When you normalize for force output, basically, accounting for the fact that older muscles might generate less maximum force, some of these measured mechanical differences diminish.
Ah, so it's not just the tendon wearing out.
Possibly not just that in isolation. It suggests that changes in the muscle's force output capacity might be more responsible for the observed alterations in the overall muscle tendon unit's function during aging, rather than just the tendon tissue itself degrading independently.
That's a really insightful distinction. It's about the function of the whole unit.
Exactly. With age, there's also increased collagen cross-linking, decreased water content, a decreased concentration of collagen overall, and often decreased blood supply. All these factors contribute to a decreased overall load capacity,
Less able to handle stress.
particularly for activities involving rapid energy storage and release, like jumping or fast running. The sources also point out that cumulative loading over a lifetime, especially a history of high-level athletic participation, seems to be a factor. Former athletes seem to exhibit higher rates of tendinopathy and rupture later in life.
Beyond age and activity history, genetics also seems to play a role. I saw that mentioned.
Yes, genetic factors are increasingly implicated in the pathogenesis, the development of tendinopathy. Twin studies, for instance, have suggested a genetic predisposition for conditions like lateral epicondylalgia.
Specific genes.
Yes, the sources mention specific genes that have been linked. One is COL5A1. This encodes a component of type V collagen.
Type V collagen. What does that do?
It's important because it plays a role in organizing the much more abundant type I collagen fibers into bundles. Variants in this COL5A1 gene are associated with more tightly packed collagen bundles.
Tightly packed. Sounds strong.
You'd think so. But while this structure might theoretically be better for energy storage, it could also potentially make the tendon more vulnerable to certain types of stress. And variations here are linked to an increased risk of Achilles tendinopathy.
Interesting. Stronger, but maybe less resilient or adaptable under certain stresses.
That's one hypothesis, yes. Another gene mentioned is tensin, or TNC. This is an anti-adhesive protein. It seems to be important in regulating how the tendon adapts to load and compression. Variants of the TNC gene have also been linked with Achilles tendinopathy, with some polymorphisms reported to increase the risk sixfold.
Sixfold. That's significant.
It is. Though the sources do note conflicting results regarding links between these genes and other injuries, like ACL tears. So it suggests the genetic influence is complex, likely specific to certain tendons or injury types, not necessarily a universal predisposition.
Fascinating how our fundamental genetic code can influence our tissue's resilience. And of course, the specific activity itself, the type and amount of load we put on the tissue, that's got to be a huge factor in who gets what type of tendinopathy.
So absolutely.
Yeah.
Huge. The sources clearly associate specific activities and biomechanics with particular tendinopathies.
Yeah.
Lateral elbow issues tennis, elbow common in manual work, gripping tasks, racket sports, especially for those over 40.
Yep.
Rotator cuff tendinopathy in the shoulder is strongly linked to overhead activity, seen frequently in both young overhead athletes and individuals over 50. Hamstring injuries are very prevalent in sports involving sprinting or stretching. And interestingly, muscle tendon dimensions.
Dimensions, like how big the muscle is.
Sort of. Like the width of the aponeurosis, that sheet-like tendon relative to the muscle width in sprinters. That ratio can contribute to susceptibility.
So individual body mechanics and proportions really matter.
They do. Patellar tendinopathy, jumper's knee, is, as the name suggests, common in jumping athletes. And things like restricted ankle dorsiflexion range might actually increase the load on the patellar tendon, increasing risk there.
Ah, a biomechanical link.
Yes. And Achilles tendinopathy is strongly associated with running and jumping activities, classic overuse scenarios for that big energy-storing tendon.
Are there other, perhaps less commonly known factors mentioned as contributing to tendinopathy risk? Systemic things?
Yes, the sources briefly touch on several important systemic or medication-related factors. Drug-induced tendinopathy, for instance.
From medication?
Yes, it can occur with certain medications, notably fluoroquinolone antibiotics, but also corticosteroids, statins used for cholesterol, and anabolic steroids.
Good to know.
Systemic diseases like lupus can also be associated with tendon issues, sometimes presenting as Achilles tendinopathy. Foot structure and range of motion are mentioned as potential biomechanical risk factors for lower limb overuse injuries.
Makes sense.
And interestingly, conditions like gout, which involves high uric acid levels, are being investigated. The inflammatory response, mediated by a specific signaling molecule in gout, IL-1, might potentially interfere with normal tendon homeostasis and repair processes.
Gout affecting tendons. That's unexpected. So the risk profile is incredibly broad then. Everything from our age and genes to the specific way we move, medications we might take, and even underlying systemic health conditions.
It really is multifactorial.
Once an injury or tendinopathy is suspected, how do clinicians figure out exactly what's going on? The sources cover quite a range of diagnostic approaches, from imaging to physical tests.
Yes, Imaging plays a critical role, but it's really important to understand the strengths and limitations of each modality based on what the sources describe. Plain X-rays, for example.
X-rays, okay. What are they good for here?
Well, they're limited for visualizing soft tissues like muscles and tendons directly, but they are invaluable for seeing bony structures.
Right. Bones show up well.
Exactly. So they're used to check for bony avulsion fractures, where a tendon is pulled off a piece of bone. Look for spurs or calcifications. Assess overall skeletal alignment. Check for asymmetry, or examine growth plates and apophysitis in younger patients where tendon attachments to bone can be vulnerable.
So good for the bone connection, less so for the soft tissue itself. What about ultrasound? That seems more suited to soft tissue.
Ultrasound is highlighted as a really valuable tool, particularly because it's dynamic.
Dynamic. You mean you can see things move?
Yes, exactly. You can assess tissues in motion, which is crucial for some conditions. This allows checking for elongation or dislocation of tendon bundles during movement, tendon subluxation slipping out of place or something like snapping hip syndrome.
Okay.
It can show clear structural abnormalities like fiber discontinuity, altered echogenicity, that's how the tissue reflects sound waves, indicating changes in structure,
Right.
hypervascularity, which often signifies unstable scar tissue or a failed healing attempt, or fluid around the lesion. It's excellent for superficial structures, like those in the hand and wrist. Very useful for diagnosing conditions like trigger finger or de Quervain's tenosynovitis.
And Doppler can show blood flow?
Yes, color or power Doppler can be added to assess blood flow, highlighting the presence of that neovascularity we mentioned earlier.
But it's not perfect, right? It must have limitations.
Yes, definitely. Acoustic shadowing from dense scar tissue, especially after surgery like an Achilles repair, can completely obscure the view deeper to the scar. Depth penetration can also be limited for assessing deeper muscles, particularly in larger individuals.
Makes sense.
And critically, the source notes that the accuracy and diagnostic yield of ultrasound are highly dependent on the skill and experience of the examiner performing the scan.
Ah, so it's very operator dependent. That's key. What about MRI? That's often seen as the gold standard for soft tissue, isn't it?
Magnetic resonance imaging, yes. It's described as a multi-parametric tool. It provides excellent detail for assessing deeper muscles and detecting even minimal changes within the tissue that might not be visible on ultrasound.
High sensitivity.
Very high. The sources cited sensitivity as 92% for detecting non-structural injuries, like muscle edema or minor tears. MRI shows characteristic signal changes representing pathology like edema, hemorrhage, bleeding, and hematoma, collection of blood. It can clearly depict fiber discontinuity or complete rupture and quantify muscle retraction, which you often see dramatically in larger gastrocnemius tears or hamstring avulsions. It allows comprehensive assessment not just of the tendon itself, but also its surrounding sheath, any fluid collections, and adjacent structures like the bicipital groove in the shoulder.
And I saw dynamic MRI mentioned as particularly useful in certain cases.
Absolutely. Dynamic MRI, where scans are taken during movement or muscle contraction, is crucial for showing lesions that might not be visible in a static image.
Like what kind of lesions?
Things like certain supraspinatus tendon tears in the shoulder, or assessing the quadriceps or hamstrings through specific ranges of motion and contraction to see where pathology occurs. It's also vital for visualizing tendon retraction or changes in patellar tendon height in chronic rupture situations where static imaging might underestimate the problem.
I see.
And MR arthrography, where contrast is injected into a joint space, can also be useful for assessing structures like the long head of the biceps tendon or detecting impingement-related labral tears in the shoulder.
Is CT ever used for these soft tissue issues? Seems more for bone.
CT scans, computed tomography, are primarily used for their excellent bony detail, as you say. They're valuable for confirming complex bony avulsions, such as from the iliac spine and hamstring injuries, and for creating detailed 3D reconstructions of bony anatomy.
Right.
They can also be used, similar to MRI, to assess changes in patellar tendon height in chronic rupture when bony landmarks are important references.
And there's a mention of some newer imaging fusion technology, combining scans.
Yes, the sources mention the use of fusion technology. This allows for overlaying current ultrasound scans onto previous MRI scans.
Oh, that sounds useful.
It's particularly useful during follow-up appointments. It enables clinicians to superimpose the real-time ultrasound view onto the baseline MRI to clearly demonstrate any changes over time, or perhaps to precisely target interventions based on the MRI findings.
Very clever. Beyond imaging, physical examination tests are also clearly key to diagnosis, aren't they? You don't just rely on the scans.
Definitely not. No, a thorough physical examination is crucial. and really goes hand in hand with imaging. The sources mention specific physical exam tests associated with different conditions, and these are woven into the discussion of specific areas.
For example?
Well, for example, the Finkelstein test. This involves specific wrist movements to stretch the tendons involved in de Quervain's disease and elicit pain. For assessing the long head of the biceps tendon in the shoulder, tests like Speeds, Yergason's, and the three-pack exam are used to elicit pain or assess the tendon stability in its groove.
Right.
And the visible bulge, often referred to as the Popeye sign.
Ah, yes, the Popeye sign.
It's a classic, though sometimes subtle, indicator of a complete biceps rupture.
I've certainly heard of that, a very distinctive physical finding.
It is. In the lower limb, for issues like tibialis posterior insufficiency, important clinical signs include the too many toes sign, where you can see more toes from behind the patient due to the foot collapsing outwards,
Right.
the heel rise test to assess muscle function, and the first metatarsal rise sign. These clinical tests, described in the sources, help clinicians pinpoint the likely problem area and guide subsequent imaging or treatment decisions.
So it's really a combination of the patient's history, a skilled physical exam, and appropriate imaging that's needed to get a full, accurate picture of what's going on.
Absolutely. You need all those pieces.
Once a diagnosis is made, how do we approach treatment? The sources clearly discuss balancing conservative and surgical options.
That's absolutely the overarching principle, yes. The decision-making process depends heavily on the injury severity, its specific location, and of course the patient's individual needs, functional goals, and overall health.
Let's start with conservative management then. This seems to be the first line of defense for many conditions, particularly tendinopathies, and the sources heavily emphasize load management as a core principle here.
Load management is presented as absolutely key, particularly in the initial phases of what's sometimes termed reactive tendinopathy, that sort of acute overload response.
Reactive tendinopathy, okay?
This involves carefully modifying the activity that aggravated the tendon to reduce symptoms while still allowing tissue adaptation. But here's a really important point the sources stress. Complete rest from tensile load is often contraindicated.
Contraindicated, so not advised.
Exactly. While it might feel intuitive to stop using the painful tendon entirely, prolonged, complete rest actually decreases the tendon's mechanical strength and capacity over time. It deconditions it.
So rest isn't necessarily best, at least not complete unloaded rest for the tendon itself.
Precisely. The goal of modifying load is to reduce painful activities, especially those high-load energy storage activities, think jumping, hopping, throwing, rapid changes of direction.
Okay.
It also means reducing compressive loads, which often occur when muscles are used in their outer ranges of motion, potentially compressing the tendon against underlying bone. The focus is on maintaining some appropriate load to stimulate adaptation and healing, just at a level the tissue can tolerate.
Right. Finding that sweet spot of loading. How does exercise fit into this load management strategy then?
Exercise progression is really the cornerstone of rehabilitation for most muscle and tendon injuries and tendinopathies. The sources describe a phased approach.
Phased approach, like starting simple.
Yes. Typically starting with simpler weight-bearing exercises, if it's the lower limb, like squats, step-downs, lunges, performed at appropriate speeds that don't provoke pain.
Okay.
As the tendon's load tolerance increases and symptoms settle, you progressively increase the intensity, which often means increasing the speed of movement, moving towards more rapid or plyometric actions.
Building up the demand.
Exactly. The final phase then shifts to highly specific, functional, and sport-specific activities, gradually returning the patient to their desired level of function and performance. The whole process is designed to gradually increase the tendon's capacity to handle load.
And monitoring that load seems particularly crucial when someone is returning to sport or high-level activity to avoid setbacks.
It is vital, absolutely vital to prevent recurrence.
Yeah.
The sources mention the concept of the acute to chronic workload ratio.
Acute to chronic workload ratio.
Yes, popularized by Blanche and Gabbett.
Yeah.
It's presented as a useful tool for monitoring load, especially when athletes are returning to sport after rehab. Training intensity during rehabilitation is usually significantly lower than normal training.
Right, of course.
So the return to full activity must be carefully managed and gradual. Avoid rapidly overloading the recovering tissue, which is a very common case of re-injury.
Gradual return is key. What about other physical therapy modalities, things like therapeutic ultrasound, massage, laser therapy? Are they supported by the evidence in the sources?
Well, the sources are quite clear. The evidence base for many of these sort of passive modalities, including low-level laser therapy, LLLT, iontophoresis using electrical current to drive medication in, therapeutic ultrasound, deep friction massage, is often limited, or conflicting, or simply not robust enough to strongly support their widespread use for promoting actual tissue healing in tendinopathy.
So, limited evidence for those passive treatments.
Generally, yes. Similarly, while exercises aimed at proprioception, that's awareness of body position and general stability, are often included in rehab programs, the sources review these and note a lack of strong positive evidence in some specific areas.
Hmm.
However, the idea of conscious control of movement to perhaps reduce potentially detrimental variability in loading patterns is still discussed, suggesting an external focus during exercises might be beneficial.
So, perhaps less emphasis on specific techniques and more on the fundamental principles of controlled movement and progressive load? What role do medications play in managing these conditions?
Medications are primarily for symptom management, particularly pain relief. NSAIDs, non-steroidal anti-inflammatories like ibuprofen or naproxen,
Right.
they can provide short-term pain relief, which might help a patient participate in their rehabilitation program. However, the sources find no evidence that NSAIDs actually promote tendon healing itself.
Just pain relief, not healing. What about injections? The corticosteroids.
Corticosteroid injections can provide good short-term pain relief, typically for up to about 6 weeks. This can be very helpful, say, for persistent lateral epicondylitis to allow someone to engage in physical therapy.
Okay, a window of opportunity.
Exactly. But they do not offer a long-term benefit. And crucially, they're associated with an increased risk of tendon rupture and recurrence of symptoms.
Increased risk of rupture. That's concerning.
It is. Therefore, the sources advise caution with their use, especially repeated injections. Nutraceuticals, things like compounds derived from plants such as bromelain, curcumin, boswellic acid, or supplements like chondroitin sulfate. They're mentioned as a relatively new area of study, often investigated in combinations, but the evidence is still emerging.
So, conservative management is primarily about intelligent load management, structured progressive exercise, and careful pain control, with caution advised for some pharmacological interventions, especially steroids. When does surgery enter the picture? When do you move beyond conservative approaches?
Surgery is generally considered for more severe injuries, specific structural problems, or when a comprehensive, well-executed conservative management program has failed to achieve satisfactory results after an appropriate period, say 3 to 6 months or more.
Okay. What kind of things warrant surgery?
Indications include complete ruptures, such as a complete tear of the patellar tendon, quadriceps tendon, or hamstring avulsions, where the tendon is pulled completely off the bone with significant retraction, often defined as more than 2 centimeters.
Right. Big tears or detachments.
Yes. Large intramuscular hematomas that aren't resolving can also sometimes require surgical drainage. Certain chronic conditions respond poorly to conservative care, like stenosing tenosynovitis trigger finger, de Quervain's where the tendon sheath is thickened, restricting movement.
Mm-hmm.
For chronic compartment syndrome, where pressure builds dangerously within a muscle compartment during exercise, fasciotomy, surgically releasing the fascial sheath, is often the treatment of choice, though success rates can vary depending on the specific compartment involved. Peroneal tendon tears or dislocations in the ankle area rarely heal spontaneously due to mechanical factors, so surgery is often required there. And finally, some chronic tendinopathies that remain debilitating despite appropriate eccentric exercise programs may also be surgical candidates, though this is perhaps less common than for acute ruptures.
What are some of the specific surgical procedures mentioned in the sources for these different issues?
Well, the sources describe quite a variety of procedures depending on the specific problem. Tendinopathy is the term for surgically repairing a torn tendon, stitching the ends back together.
Tendinopathy. Got it.
Muscle avulsion repair involves reattaching a muscle tendon unit that is pulled away from its bony insertion. The sources note that early repair generally leads to better functional outcomes.
Early repair is better.
Generally, yes. For the long head of the biceps and the shoulder, procedures like tenodesis, cutting the tendon and reattaching it elsewhere, usually lower down, or tenotomy, simply cutting the tendon, are discussed. Studies show potential differences in strength outcomes and the likelihood of that Popeye sign occurring. Debridement involves surgically removing degenerative or damaged tissue from within a tendon. Seen for Achilles, patellar, and peroneal tendons, augmentation procedures use grafts.
Grafts, like adding tissue.
Yes, either autologous from the patient's own body, allogeneic from a donor, or sometimes synthetic mesh. These are used to reinforce repairs when there's insufficient native tendon substance, perhaps for large quadriceps ruptures.
Okay.
Release procedures involve surgically cutting structures that are constricting tendons, like the A1 pulley and trigger finger, which can be done percutaneously with a needle or openly, or releasing structures like the IT band or the popliteus tendon in certain syndromes, fasciotomy for CECS, as we mentioned, and tendoscopy.
Like keyhole surgery for tendons.
Exactly. A minimally invasive technique using an endoscope. It can be used for debridement or synovectomy,
Right.
removing the inflamed lining of the tendon sheath, in areas like the tibialis posterior or anterior.
That's quite a comprehensive list of interventions, and I imagine post-operative management and rehabilitation is just as critical as the surgery itself for determining the final outcome.
Oh, absolutely. Postoperative management and rehabilitation are paramount. There's still some variation in surgical protocols regarding immediate post-op management, balancing strict immobilization versus early controlled motion.
The immobilize versus move early debate.
Exactly. However, the sources highlight evidence, particularly from animal studies, suggesting that early controlled mobilization generally enhances healing and decreases the formation of restrictive adhesions compared to prolonged immobilization.
So moving early helps.
Controlled movement, yes. Applying controlled load early in the healing phase seems to support the regeneration and remodeling of the extracellular matrix. The sources even mention a randomized controlled trial showing that functional weight bearing enhanced the early healing response in Achilles rupture repairs.
Interesting.
It's a delicate balance, of course, but early protected loading is often preferred over prolonged immobilization these days. A key point reinforced in the sources, however, is that even a successfully surgically healed tendon rarely, if ever, fully regains the original strength and mechanical properties of the native uninjured tendon.
That's a very important expectation to manage for patients undergoing surgery. So we've covered the basics, mechanics, injuries, diagnosis, and the established treatments. But there's also this growing, exciting area of newer, more biological treatments aimed at optimizing healing, aren't there?
Yes, this is a rapidly evolving field, really focusing on harnessing the body's own healing mechanisms or introducing biological factors to enhance tissue repair, particularly for chronic or complex cases that perhaps don't respond well to traditional approaches. Platelet-rich plasma, or PRP, is one such approach that's gained significant attention and use.
PRP. Yes, we hear about this a lot, especially in sports medicine. How does it actually work, according to the sources?
Well, PRP is derived from the patient's own blood. A sample of venous blood is taken and processed, usually by centrifugation, to concentrate the platelets into a small volume of plasma.
Concentrated platelets,
Yeah.
okay.
The key is that activated platelets release a powerful cocktail of growth factors and structural proteins. The sources list several key ones: platelet-derived growth factor, PDGF, transforming growth factor beta, PGFA, insulin-like growth factor, IGF, fibroblast growth factor, FGF, epidermal growth factor, EGF, and hepatocyte growth factor, HGF.
A whole alphabet soup of growth factors.
Indeed, along with structural proteins like fibrin, fibronectin, and vitronectin. These factors have several potentially beneficial effects. They enhance DNA synthesis in local cells, promote chemotaxis, which is attracting essential healing cells to the injury site.
Calling in the repair crew.
Exactly. They stimulate angiogenesis, the formation of new blood vessels, crucial for bringing nutrients in cells. And they increase the deposition of collagen and other extracellular matrix components necessary for tissue repair.
So it's essentially delivering a concentrated dose of the body's own healing signals directly to the injured area.
Precisely. That's the idea. And importantly, the sources note that these growth factors are released very rapidly upon platelet activation, about 70% within the first 10 minutes and nearly 100% within an hour.
Wow, quick release.
Yes. PRP's increasing use is particularly relevant in tissues like tendons, which often have a relatively poor blood supply, meaning the natural delivery of healing factors might be limited. While evidence is still accumulating and robust trials are awaited in some specific applications, it's certainly being explored and used for both muscle and tendon repair.
Are specific individual growth factors also being studied for their potential in tendon repair, separate from the mix you get in PRP?
Yes. Well, PRP provides that broad spectrum of factors. Specific individual growth factors like HDF, RHP, GDF-BB, which is a predominant form of PDGF, IL-6, interleukin-6, TGF-V, and various BMPs. bone morphogenetic proteins, known for bone healing but also involved in soft tissue. They are being studied for their effects on tendon repair.
But more experimental.
Much of this research is currently in animal models or early clinical trials, yes.
Yeah.
The results can be promising for stimulating certain aspects of healing, but they require much further clinical investigation to determine their overall effectiveness and safety in human patients compared to other treatments.
And what about stem cells? That's another area often discussed in regenerative medicine circles.
Mesenchymal stromal cells, or MSCs, often referred to as stem cells in this context, are being explored for their potential in tendon healing. This is based on their ability to proliferate, to multiply, and their immunosuppressive properties, which could potentially modulate the inflammatory response.
Okay. How are they being used?
They are used in both veterinary medicine, particularly in horses, and are being investigated in human medicine. However, the sources highlight that the optimal conditions for effectively inducing genuine tendon healing using MSCs, particularly how to introduce them into the injury site and guide their behavior, are still largely unclear and require significant research.
Still early days for stem cells and tendons then.
Relatively, yes. There's also research looking specifically at fat-derived stem cells and how different factors in their environment might influence their morphology and growth patterns towards becoming tendon-like cells.
So still very much an area of active research to optimize their application and effectiveness. What if the injury is very large where you actually need to bridge a significant gap in the tissue?
That's where biomaterials and scaffolds come into play. They can play a crucial role, especially in augmenting surgical repairs for large tendon defects where there simply isn't enough native tissue to stitch together.
Scaffolds, okay. Like a framework for healing.
Exactly. Synthetic scaffolds have been developed, but they face challenges. Things like perfectly matching the mechanical properties of native tendon, ensuring controlled degradation over time, and ensuring the body's cells interact favorably with the synthetic material. Newer synthetic materials aim to transfer load gradually to the forming tissue as they slowly degrade.
And what about scaffolds derived from natural tissues? Are they better?
These are extracellular matrix-derived scaffolds, often from animal tissues like pig intestine or dermis. They contain native growth factors and proteins, and the hope is they can provide a more natural environment to induce constructive remodeling by the host tissue.
Sounds promising. Any drawbacks?
Well, the sources mention a challenge here. FDA standards for tissue decellularization, and that's the process of removing the original animal cells from the matrix to reduce immune rejection, are not fully established or consistently applied.
Ah, so variability in the products.
Potentially, yes. This means commercially available products can vary in the amount of remaining antigenic material, which could potentially cause unwanted immune responses or complications. These scaffolds are often used in combination with biological treatments like PRP or stem cells.
Right, combining approaches. Let's shift gears slightly to extracorporeal shockwave therapy, or ESWT. This is another non-invasive treatment method often used for chronic tendinopathies. How does it work, according to the sources?
ESWT involves applying mechanical shock waves to the affected tendon area using a specialized device. The sources describe these waves as having a characteristic profile: a very fast, high-amplitude positive pressure rise, followed by a lower amplitude negative pressure phase.
Shockwaves. Sounds intense. How do they help?
The proposed mechanisms are multifaceted. It's thought to have a direct analgesic effect, providing pain relief. Crucially, it's also proposed to work through mechanotransduction.
Mechanotransduction, like the cell's sensing force.
Exactly. Essentially waking up the tenocytes and stimulating a biological response that leads to tissue regeneration and remodeling. It's also thought to potentially help dissolve calcifications that can be present in some tendons.
Is the evidence supporting ESWT's effectiveness consistent across all tendinopathies? Or is it better for some than others?
The sources note variability in the evidence. For example, they state there is moderate evidence supporting its use for patellar tendinopathy.
Moderate evidence.
They also discuss reasons for the sometimes conflicting or controversial results seen in research studies. These include differences in methodology between studies, variations in how patients and their specific type or stage of tendinopathy are selected, and significant heterogeneity in the ESWT systems used: the treatment protocols, energy levels, number of pulses, frequency, and the study populations.
So lots of variables making comparisons difficult.
Precisely. It's sometimes positioned as a potential biosurgery tool due to its ability to stimulate biological responses, but the sources conclude that further research is needed, including exploring its potential role in treating tendinopathies linked to underlying metabolic disorders.
Okay, Finally, there's a mention of a very specific, quite novel treatment approach called Goldie treatment. This sounds quite distinct.
It is quite distinct, based only on the description provided in the source material here. Goldix treatment involves incubating a sample of the patient's own venous blood with specially prepared gold particles for a period of 24 hours.
Incubating blood with gold.
Yes. The process then involves analyzing the resulting mixture using a specific spectroscopic method called aquaspec. This uses mid-infrared spectroscopy to measure the proteomic pattern, essentially, looking at the profile of proteins present.
And the purpose of the gold.
The stated goal of this incubation process with gold particles appears to be to increase the levels of specific anti-inflammatory mediators in the blood sample. The sources specifically mention increasing levels of interleukin-1 receptor antagonist, IL-1RA, and soluble TNF-alpha receptor 2.
So, boosting anti-inflammatory signals in the blood sample.
That seems to be the aim described.
And what are the results cited for this approach? Any evidence?
The source mentions an observed positive effect in horse studies. In human cases, it cites MRI documentation showing improvement in chronic Achilles tendinosis in an 80-year-old patient. It also notes that this specific process did not appear to affect the expression or levels of certain other interleukins and chemokines that were tested. So it's presented as a very specific, gold particle-mediated approach aimed at modulating inflammatory mediators within the patient's blood before it's potentially used as a therapeutic injection. Still sounds quite experimental based on this description.
Okay, we've covered an immense amount of ground, really, from the very structure of these tissues all the way to cutting-edge treatments. Let's briefly touch on some specific areas or conditions highlighted in the sources that might resonate most strongly with listeners, sort of connecting this back to common experiences of pain and injury.
Certainly. In the lower limb, for instance, hamstring injuries are very prevalent, particularly in sports involving sprinting or stretching. And as we discussed earlier, factors like muscle tendon dimensions can play a role in vulnerability, especially in sprinters.
Right. Hamstrings are notorious.
They are. Achilles tendinopathy is another extremely common issue, particularly in runners and jumping athletes. And the sources note that identifying the precise sources of pain in this condition can actually be complex, requiring very careful assessment. Patellar tendinopathy, jumper's knee, also frequent in jumping athletes. Effective load management is absolutely critical in its treatment, and it's recognized that there are different stages of the condition which influence management.
What about issues further down in the foot and ankle area?
Tibialis posterior insufficiency is discussed, often linked to the development of acquired flat foot deformity. The sources emphasize the need for early diagnosis here to potentially prevent progressive issues. Peroneal tendons on the outside of the ankle are also mentioned. Injuries or subluxation, slipping out of place, are sometimes missed, particularly in sports involving cutting movements.
Easy to miss.
Apparently so. Plantar fascia issues are a very common cause of heel pain, and imaging like ultrasound is highlighted as useful for confirming the diagnosis by showing thickness or structural changes. And chronic exertional compartment syndrome, CECS.
CECS, yes.
Another lower limb issue detailed characterized by that exertional leg pain that typically resolves with rest but comes back with activity, often with a significant delay in diagnosis. Surgical fasciotomy is frequently the treatment of choice, although outcomes can vary.
Moving up the body then, what about common issues in the upper limb? Arm, shoulder.
Lateral epicondylitis, tennis elbow, is a very common tendinopathy affecting the elbow extensor tendons, often linked to repetitive gripping or wrist movements. In the shoulder, long head of biceps, LHB pathology, is discussed as a common source of anterior shoulder pain, frequently linked to other underlying shoulder issues like rotator cuff tears or labral problems. Specific physical tests are important for its diagnosis.
LHB, okay. And hand wrist.
Yes, the hand and wrist are particularly prone to repetitive strain injuries, leading to various conditions involving tendons and their sheaths, like trigger finger or de Crevaine's disease.
And finally, the hip and groin area, often complex.
Very complex. Tendinopathies around the hip can involve muscles like the iliopsoas, a hip flexor, and the rectus femoris, part of the quadriceps. Proximal hamstring issues, where the tendons attach high up near the sitting bone, are notable due to their close proximity to the sciatic nerve, which can lead to referred pain or nerve symptoms.
Sciatic nerve involvement.
Yes. Groin pain itself is often complex, involving multiple structures, including adductor tendons, and the sources link it to underlying structural issues, like femoroacetabular impingement, FAI, in the hip joint.
It's clear these intricate tissues are involved in pain and dysfunction across the entire body in such a wide range of activities. As we begin to wrap up this deep dive, building on everything we've discussed, what are the key challenges that researchers and clinicians are still grappling with, and what does the future hold in this area?
Well, the sources certainly highlight that despite significant progress, important knowledge gaps remain. For instance, determining the absolute optimal exercise protocols, the perfect dosage of load, speed, frequency for different stages and types of tendinopathy is still being refined.
Finding that perfect recipe.
Exactly. Our full understanding of exactly what causes damage within that critical muscle-tendon junction in seemingly healthy tissue under certain loads isn't yet complete either. And as we discussed, the precise mechanisms of action for some newer treatments, like ESWT for example, need further detailed research.
And there are areas where the evidence is still conflicting or maybe unclear?
Yes, definitely. For certain specific rehabilitation modalities or the precise genetic links to injuries other than specific tendinopathies, the research results aren't always clear-cut or consistent across studies. There's a clear need for more robust research and greater standardization.
Standardization in what sense?
For example, in how PRP is prepared and applied clinically to ensure consistent results, or in the complex processes involved in tissue decellularization for grafts, as we touched upon.
Right, so consistency and more high-quality evidence needed. What's the final takeaway regarding managing these conditions, especially for those listening who might be experiencing these issues themselves or perhaps working with people who are?
I think the sources reinforce that while tendinopathy is often manageable and symptoms can be significantly improved, it's not always curable in the sense of returning to a completely pain-free pre-injury state, particularly for high-level athletes.
Not always a complete cure, then.
Often it requires a long-term management perspective, focusing on building tissue capacity through carefully managed load and integrating strategies to allow successful return to sport or desired activity, and then maintenance of function over time. It's often a journey of adaptation and management, not always a simple fix.
A journey of adaptation and management. That's a really good way to frame it. This has been incredibly insightful, truly taking us from the nanoscopic structure of these tissues all the way to the clinical challenges and the cutting-edge treatments.
It's a fascinating area.
It really is. To recap just a few key takeaways from this deep dive. We've seen that muscle and tendon tissues have remarkably complex hierarchical structures, precisely organized for transmitting load efficiently. They are dynamic, living tissues that constantly respond and remodel based on the mechanical loads we place on them via these intricate cell-driven processes.
Absolutely key.
Tendinopathy, particularly chronic forms, is often characterized by degeneration and a failed healing response rather than simple inflammation, a really crucial distinction.
Yes, fundamental.
Diagnosing these issues requires a multifaceted approach, combining careful clinical examination with understanding the strengths and limitations of various imaging techniques like ultrasound and MRI.
Essential for accuracy.
Load management and progressive exercise, rather than complete rest, are the absolute cornerstones of conservative rehabilitation, aimed at building tissue capacity.
The foundation of recovery.
And finally, the landscape of biological treatments like PRP and shockwave therapy is evolving, offering new avenues to potentially optimize healing, although more robust research is still needed to refine their use.
Indeed. Understanding that intricate biological and mechanical dance within these tissues is truly key to both preventing injuries where possible and effectively treating them when they occur.
It really leaves you with the thought that perhaps the future of managing these incredibly common, often debilitating conditions lies in better understanding and ultimately harnessing the body's own remarkable healing mechanisms, guided by that fundamental principle of applying just the right precise load at the right time.
A hopeful thought for the future.
If you found the insights in this deep dive valuable, please do take a moment to rate and share it on your professional networks like LinkedIn or X.
Sharing knowledge helps advance understanding for everyone.
Absolutely. That's all for this deep dive. Thank you so much for joining us and sharing your expertise.
It's been a real pleasure. Thank you.
Until next time.